Good afternoon. If you can hear me, just wave your hands. Let me know that we have someone out there. Thank you, Demetra. Thank you, Jeanette and Ashley and Marissa. Okay, it is 12:02, and in the interest of time, and for those of you who joined us on time, we will go ahead and get started with Webinar Wednesday. And good afternoon. On behalf of Sisters Network Incorporated, our National Board of Directors, affiliate chapters, staff, and volunteers, welcome to Webinar Wednesday, hosted by Sisters Network and sponsored by Cancer Treatment Centers of America and Iman Cosmetics, and also in partnership with the Breast Health Collaborative of Texas. I am Kelly P. Hodges, the National Program Director for Sisters Network and facilitator for today's webinar. As many of you know, Sisters Network is a leading voice and the only national African American breast cancer survivorship organization in the United States. Founded in 1994 by Karen E. Jackson, Sisters Network is governed by an elected board of directors and assisted by an appointed medical advisory board. The organization's purpose is to save lives and provide a broader scope of knowledge that addresses the breast cancer that addresses the breast cancer survivorship crisis affecting African American women around the country. Sisters Network is very excited about Webinar Wednesday. This is one of our just one of many successful projects that we have currently going on within the network. And thank you to those of you who have participated in previous webinars. But if you've missed them, the webinars are on the homepage of our national website. You can also connect with those webinars uh, on the left navigation bar of our the homepage of our website under News You Can Use as well. And our national website is sistersnetworkinc.org. And you can also see the recorded YouTube from our YouTube channel, Sisters Network INC. Just a quick note before I introduce today's presenters. The Q&A session will take place at the end of the presentation. Please note your questions and hold until the end, and we'll make every effort to address all questions. Any additional questions can also be emailed to kate.peterson@ctca-hope.com, and we'll have that information available on the screen towards the end of the presentation. As I mentioned, Sisters Network aims to provide useful and informative information to survivors, caregivers, health professionals, or those who want to know more about healthcare, breast cancer, and survivorship. So without further delay, I would like to introduce the two speakers for today. Let me advance the slide. Our two speakers for today are Britt Hermann, survivorship social worker, and Heidi Larder, a survivorship nurse from Cancer Treatment Centers of America. Britt Hermann earned her bachelor's degree from Carthage College in Wisconsin and completed her master's in social work at Loyola University in Chicago. She's a licensed social worker with experience in sexual abuse counseling and community outreach, including prevention programs for teens and couples counseling. She is currently seeking her sex therapy certificate from the University of Michigan. Hermann joined Cancer Treatment Centers of America in 2013. As a survivorship social worker, she focuses on helping patients reclaim their sexuality after treatment, whether that means exploring physical barriers, communication with partners, or improving body image. Her goal is to allow survivors to cultivate their own solutions on the path to sexual health and personal growth. Heidi Lauder earned her associate degree in nursing from the College of Lake County in Illinois. She completed both her Bachelor of Science in Nursing and Master's in Nursing at Olivet Nazarene University in Illinois as well, with a focus in education. She is currently seeking a certificate program for family nurse practitioner through which she plans to further expand the offerings to patients concerning sexuality after cancer treatment. Lauder is an experienced oncology nurse and joined the survivorship team in 2008. Her role includes walking patients through the journey of surviving cancer, including complications concerning sexuality. She is committed to increasing awareness of sexuality concerns and delivering better outcomes for sexuality issues. Ladies, thank you so much for presenting today. I will now turn and Britt. Thank you so much.
Thank you so much for that kind introduction. We're very excited to be here today, and we want to thank all of our participants. We're going to be talking about sex and intimacy, and we'll get more into why we separate those two words in our presentation. Some of you may be wondering what the difference between sex and intimacy are. I'd like to turn it over right now to Heidi, who's going to give us a little introduction about the CTCA model on our patient empowered care.
Hello, and thank you again for having us. As you can see on the screen right now, this is just a simple model that we have here at Cancer Treatment Centers. We are very patient-centered, so you can see the patient is right at the middle there of our model. And then we push all the clinicians around the outside. So we're all focused right in on the patient, and the way the circle is the way it is because we all talk to each other as well. So communication between clinicians and different departments is very important to us as well.
So we just want to welcome everyone who's joining us and really ask you to ask yourself the question, what do you hope to learn today? As our host has mentioned, there will be a Q&A at the end. We want to make sure that if we're not getting to some of the specific content that you'd like to know about, that you keep that in the back of your mind during our presentation and you do ask us at the end. Or if you want to send an email to Kate too, that would be fine. But just to be really mindful that we want to answer all of your questions. And so if we don't get to something that you're curious about, please do feel free to ask. So Heidi and I are in the survivorship department here at Cancer Treatment Centers of America. And in survivorship, we're really looking at the long and late-term effects of treatment. So every patient that comes into our department is actually asked some pretty specific questions about some common issues that they may be experiencing due to cancer treatments. Some of the really common issues that we're seeing include things like fatigue, changes in weight after treatment, pain and pain management, feelings of depression and anxiety, and sexual problems.
So in our meetings with patients over time, we've really noticed that sexuality is a huge concern for our cancer patients. So at least half of all patients with cancer have some type of sexual dysfunction after treatment. But personally, I would say that number is probably a lot higher, but that's what the literature reports, so that's what we have to report as well. But I would say it's definitely closer to 80% of patients that we meet with at least report some type of issues with sex after cancer. We do most commonly see this in breast and gynecologic cancer for women, and then prostate cancer for men. But really, treatment can affect any type of any cancer type can affect sexual health after cancer treatment. Looking at sexual health and intimacy, like I said, we have noticed that it's a top concern after treatment. There's a lot of attention that is turned towards quality of life after treatment. So, a lot of patients say that after they go through something like a cancer crisis, that they are more attuned to what's important to me now. What are some things that I want to change about the way life is now? Treatments may have changed the way the body responds and the way people feel about themselves as sexual beings. So sometimes it may not be the first thing on the patient's mind during treatment, but there is hope for reclaiming sexual health after treatment.
And thanks to improving technology, people are living better lives after treatment. Due to these advancements, there's an increased focus on quality of life, and that includes talking about sex after cancer. Even though our culture is absolutely saturated in sex, it's in our media, it's in our advertisements, it's on TV. When it comes to discussing our specific sexual behaviors. We suddenly feel shy or embarrassed, even with those who could help, like our healthcare professionals. Many cancer survivors find that what was once sexually pleasing to them no longer is, but find a barrier in talking to healthcare professionals about this. One thing that sex is not, and we really like to emphasize this, is it's not one size fits all. Sex can be pleasurable, it can be romantic, it can be awkward and boring, it can be exciting, and this can occur all over the course of a lifetime. Sexual experiences really can have a huge range. As we meet with people, we've come to realize how important it is to explore how past experiences, belief systems, and culture build this idea of a sexual self schema. And this is maybe a word that many haven't really explored a lot. A sexual schema can be compared to like an operating system on a smartphone. It's what helps you decide, act, and form opinions on things. And when it comes to sex, this is a really important concept to understand as healthcare providers, but also as individuals. For example, the idea of self pleasure or masturbation is as sexual or as natural as sex itself for some people, but for others, it's not. Understanding where these views come from and how we really interpret this information is really important in coming up with possible solutions to sexual dissatisfaction. I'm sorry.
The other important thing to explore is how well a person understands the sexual response cycle. And Britt and I were actually talking about this slide right before our presentation and how simplified this model really is. And this model actually is highly scrutinized amongst healthcare providers as well. But looking at this simple model, you can kind of look at how there are a few steps that people kind of generally go through in the sexual response cycle. So there's an excitement phase, a plateau phase, an orgasm, and then a resolution. And again, because it's highly simplified, this model isn't perfect. It leaves out desire, and it also assumes that every sexual experience would include an orgasm, which we'll try to help you understand today that just may not be true. But it can also help to just kind of demonstrate what a typical sexual response cycle may be for a man.
So, a model that makes more sense to us is actually Rosemary Bassan's nonlinear model. And this is oftentimes applied for females, but we believe it also is very effective for understanding the, kind of the human sexual response cycle better. It incorporates a need for intimacy. It acknowledges that desire can be spontaneous or reactive. It recognizes that orgasms aren't necessary, as Heidi has mentioned, and it takes into account emotional satisfaction. And this slide really helps illustrate that better. As you can see, there's wiggle room for things like spontaneity, motivation to seek intimacy, and openness to sexual stimulus. The most important thing to remember for both males and females is that sex is not the same thing as intimacy. So, touch, affirmation, closeness, these are all part of the sexual package and incorporate within the sexual response cycle this idea of seeking out and being receptive to sexual stimulus. As healthcare professionals, we talk to patients every day about reclaiming sex after treatment, and we like to use this model. It's called the Plicit model for sexual intervention. It kind of consists of guidelines for how to talk to patients in a comfortable way. It starts with asking for and giving permission to talk openly about sex. That may mean giving patients permission to talk openly without guilt or shame. And it also incorporates this idea that the healthcare provider's energy in the room is very important. So, just if a patient or a healthcare provider is squirming in their seat, there's suddenly this barrier in the room to talking about sex. The next step is providing limited information about anatomy or pleasure. We provide specific suggestions that are practical and fit within the individual schema. And if need be, we offer or refer for longer intensive therapy.
So, looking at sex during and after treatment, we actually used to only meet with patients after treatment was completed. And this became something where I believe that healthcare providers kind of had it in their heads that patients just weren't interested in sex during treatment. But we've really found that that may not be the case. There's a lot of patients that are ready to go as soon as the doctor gives the nod of approval. So we do definitely want to open this conversation to not only patients after treatment, but also during treatment. What are some ways that I can still be intimate with my partner? Um, yeah, there we go. Okay, so concerns during treatment. We just wanted to outline a few of the concerns that we see as some of the things that people deal with during treatment and even after. But specific guidelines from the surgeon are very important. So when a patient has surgery, we always have to look for those guidelines to kind of when can I have sex again? You know, what is the appropriate time for me? For radiation, we do find that patients are usually mostly concerned with pelvic radiation and just needing to know what exactly could be happening to my pelvis and that type of thing during radiation. It does talk about on here having a PSA test. Some doctors won't want you to have sex before a PSA test, so that's something that definitely has to be talked about with the healthcare provider as well. During chemotherapy, there are some general guidelines, and so outlining those for patients just so that they're aware of any of the risks that are there. Um, Platelet counts definitely need to be above 50,000. The ANC, which is a particular count that looks at your white blood cells, that needs to be at least 1,000. So these are things to prevent bleeding risk and also infection during treatment. So we definitely have to outline these things for patients and make sure that they're aware. Also, waiting 72 hours after chemotherapy infusion is important. Patients ask us, you know, am I toxic? Am I poisonous? Things like that. And we just want them to know that really the answer to that is no, but waiting 72 hours is the best and most appropriate thing for the partner of the patient. Many patients also experience nausea or fatigue during treatment, and a lot of times that does cause little to no libido, which is just something that we need to explore with patients as well.
Okay, I'm going to go over some of the physical concerns that we see with many of our female patients. These things, you know, when you're looking at this, this is obviously a common list, and there individually there may be other concerns too that we hear from patients. This is the most common list that we have. The first one is painful intercourse, and that's obviously really broad and could be caused by things like vaginal dryness. There's often changes in vaginal size depending on the treatment, and that could be a narrowing or a shortening of the vagina. It could mean a tightening of the vaginal wall. There's lack of desire or low libido. Oftentimes, patients report symptoms of menopause that are treatment induced. There's changes in sensation, so that could mean in the breasts, in the nipples, in the vagina or the clitoris. There could be issues with orgasm, so inability to reach orgasm. Again, that may be caused by low libido or changes in sensation. And then obviously there's fertility concerns as well. Some of the emotional impacts that females report to us are fatigue or feeling very tired. Radiation and chemo can cause fatigue for up to a year or two after treatment. There's body image concerns. There's a disconnect from the body as a source of pleasure. Oftentimes, when we go through an illness, um, our body isn't necessarily a source of pleasure during that time. And so they feel slightly disconnected from pleasurable experiences. There's relationship changes. Oftentimes, a illness becomes a crisis in a relationship and can change the way that your partner views you or you view your partner. Um, And then there's anxiety that's reported as well.
So in survivorship, we really like to focus on solutions. So, like we've said before, we really look to the patient to kind of help us know exactly what they're comfortable with and that sort of thing. But these are some common solutions that we probably would use with many different patients. The first thing I want to point out on this slide as well is that if sex hurts, you definitely need to stop. There is actually some vaginal trauma that can take place, and that can actually cause further problems that we really don't want to have to go there. So, definitely, if sex is hurting, we need to tell you that it's very important that you stop and seek help for that. So, what we're working on with patients a lot of times is this idea of moisturize, lubricate, and stretch. And we have a lot of patients ask us, we say, are you using a vaginal moisturizer, which is something that's listed here. And a lot of patients say, oh yeah, I'm using a KY jelly when I have sex. Well, the difference between a moisturizer and a lubricant is very important. So a lubricant is like a KY jelly. It's a water soluble product, and it's generally used just for intercourse. Whereas a moisturizer is very different. When we use a moisturizer, it's the same idea as what we use, like a Lubriderm lotion that we would use on our legs every day. It's the same idea. A vaginal moisturizer you generally use about 3 times a week. An example of this product is Luvena. That's the one that we recommend, which is a hormone-free product. And basically what it's going to do is go in there and help the vaginal walls to become more supple and less susceptible to painful tears and friction.
And I'm sorry, Heidi, I'll interject here that although Luvena is a very nice product and something that we hand out in sample form in our office, we've also had patients that really enjoy using a natural oil, like a vitamin E oil capsule, that they would actually insert into the vagina, or something like a coconut oil. Really, what we're looking at is improving that, like Heidi said, improving the integrity of the tissue. We want that tissue to be supple and moisturized. And it's very important to talk to your healthcare providers before you go ahead and start using a product. But there are other options available. Luvena is just one of the products that we have had success with and we give to our patients in our office.
So the use of a dilator to stretch the vagina is also very helpful for patients that are experiencing tightness of the vaginal walls. So this actually, over time, with a use regularly, can help to increase the circumference of the vaginal wall. And I'll just stop here for a minute and talk about a particular patient that we had come in. Um, she actually was a patient that was not in a partnership at the time. She had actually lost her husband a few years before, but she was going to her gynecologic exams, and this is a breast cancer patient. So, not always talking to the oncologist necessarily about her vaginal area. So, going into the gynecologic regular exam and just really having trouble with that exam. And she noticed over the past couple of years that it was getting worse. So she talked to her gynecologist and asked, what's happening? You're having to use a smaller speculum now. What's going on? And the gynecologist, was very knowledgeable in just telling her, well, what's happening is vaginal atrophy. It's basically because you're not having sex, and so your vaginal walls are tending to close. This is also a woman that was in menopause, so her estrogen levels were also going to be lower at that time as well. So we really worked with her to kind of come up with. She had a, she actually had a routine of kind of taking care of herself anyway. So we talked about some different things that she could do, kind of during that hygiene routine, to be able to also moisturize her vaginal walls and help to stretch her vaginal walls. So it kind of became part of what she did on a regular basis. And we met with her again a couple months later, and she reported how much, progress had really been seen in this. So she was really excited to be able to report that to us, to say, that now as she goes forward, her gynecologic exams are going to be more comfortable, and then as she, may select a partner at some point as well, that she would be ready for sex at that point too. So the last thing on this slide is really talking about the fact that a physical exam by a physician is important. And we do want to stress that as well. And one other solution that we look at sometimes is sending a patient to physical therapy for pelvic floor exercises. And we've actually looked at some different ways. There are some kind of more creative ways that we can get insurance coverage for these pelvic floor exercises, which can be a very important part of vaginal health as well.
All right, so this next slide is meant to give you a chuckle. The idea here is that when we're talking to women about solutions for any sort of sexual concerns, it's a lot different than talking to a man. As you can see on the top of the slide, a man's, and obviously this is just meant to oversimplify and provide this comedic relief, but a man, their physical concerns are so important. And so obviously you see one light switch. And for women, and we often use this when we're talking to patients, it's like a switchboard of a complicated system that everything kind of needs to be in play for things to work out and for desire and arousal and orgasm to exist. And we really like to look at this as an opportunity, that if you're having a physical barrier or there's an emotional preparedness that's not there, then there are so many other switches and gadgets and things that we can adjust to kind of improve sexual arousal and desire. Really, when we find patients, females that come to us, oftentimes the physical barriers are the least of the concerns. And again, I'll go back to this emotional preparedness for intimacy after cancer is a big deal. Some patients are having body image concerns that are causing them to feel that intimacy isn't something that they want to seek anymore. And so, whereas a patient, we recently had a patient who said, normally in her 20-year relationship, she would just strip down completely nude with her partner. And this isn't something she was comfortable doing anymore. And it was such a barrier to having intimacy and having sexuality with her partner that we really needed to explore other options and kind of give her permission to take it slow and maybe find something sexy that, a lingerie or a camisole or a bra with a prosthetic that made her feel better, and really communicate to her partner the importance of, listen, I want to leave this on during intimacy because it helps me feel good about myself. So really there are so many opportunities when we're working with women to go around things, that are just beyond that physical barriers to sex. Again, I'd like to share, this is an opportunity to share another interesting story. We had a patient who had come to us because she said she had low libido. And when we were talking to her, we had discovered that she had been pulling back from her partner. She had been sitting farther away from her partner on the sofa in the evening. She had kissed her partner fewer times because she was so afraid that these signals would be misinterpreted. She was having painful intercourse. She wasn't physically ready to have sex, but she had pulled back her intimacy as well. And so oftentimes we explore these types of situations with patients and just say, listen, it might be helpful to just talk to your partner and tell them, listen, on Saturday, I do want to have intercourse, but on Monday through Friday, I just want to cuddle. And I don't want cuddling to send the wrong message or lead to anything. And so we really explore that with patients, looking at their specific needs and wants and what's missing in their communication with their partner so that they can achieve intimacy, which involves things like hugging, kissing, touching, affirmation, all those things are part of intimacy, but don't actually include any genital touching. So that's really that difference between intimacy and sex, is that intimacy is a very important human need, where and sex is as well. But when there's a barrier to actually having intercourse, it's so important that we acknowledge that intimacy is still very important and very possible. And oftentimes sexual rehabilitation starts with reigniting intimacy. So I'm going to go over some of the physical concerns for males. And I wanted to acknowledge that we understand our audience today is mostly females. And we really wanted to mention the physical concerns for males because oftentimes our illnesses don't live in a bubble. Our partners are also having problems, whether they're age related or illness related. And we wanted to make sure that we were acknowledging that um, in a couple, there's often more than just the problem for the female. So some of the problems that we like people to be aware of for the males is changes in erections, whether that's due to health issues or even just age-related changes in erections. Erections can get weaker, difficult to maintain. With age comes sometimes this lack of sexual interest or desire that's also related to many cancer treatments. There could be changes in orgasm or ejaculation and urinary leakage. Men also experience some of the same emotional impacts that females have. There may be changes in body, changes in self concept. How am I still a man if I can't have an erection, or if I'm not having sex once a week? I'm starting to lose interest. Does that say something about my masculinity? There's a lack of communication very often, so I don't feel like I can communicate my intimacy needs, which leads me into the next PowerPoint point, is that many times men don't clearly understand their strong need for intimacy because it's being fulfilled during sexual intercourse. And so when intercourse, whether over the course of a relationship becomes less, they don't understand their strong need for intimacy still. So that's something that we talk about often.
So, in looking at some of the solutions for men, a lot of people ask us about Viagra, Cialis, or Levitra, which are all oral prescriptions that can help a man to have an erection. And most men know about these options. They've seen the commercials. They know that patients can ask for these things. A lot of men, again, are maybe a little more shy to ask for them, but usually we can at least start there. But a lot of times for patients that have experienced lower libido due to some type of hormonal treatment, Viagra or Cialis is not going to work for them. So we do have to look at some other options, and there are several different other options. So looking at suppositories, which is a tablet that's just inserted into the urethra, works very well for a lot of men that fail using Viagra or Cialis. There's also injections, and a lot of men do look at me like I'm crazy when I mention that there are injections available. But then they do kind of calm down when I show them the needle and the fact that it is a very, very tiny needle. And it's something that they're also doing themselves. Also, a lot of men kind of light up a little bit when they realize with an injection they can have an erection in about 30 seconds as well. So sometimes that is a really good alternative for men that can't use Viagra or Cialis. There's also several different things that happen for patients after treatment that may just cause an erection that can't be maintained for actual intercourse. So if a patient is experiencing something like that, sometimes we can use something like a constriction ring, which is just a tiny loop that can be placed around the base of the penis and helps to hold the blood into the penis so that they can actually experience intercourse. We can also have patients use a vacuum pump, which helps just to pull the blood into the penis. And so a lot of times those are very effective. They're also safe and a one-time cost. So sometimes that's a really good option for patients. And we work with patients for insurance coverage on those things as well. Some men are ready for surgery as well. So we look at penile prosthesis and implants, definitely exploring with them the fact that they never will have a natural erection again with those types of surgeries, but knowing that they can always have an erection anytime they would like to as well. And we do consult with urologists here at our hospital to look at someone who is specialized in erectile dysfunction, because that is a very important need for men that are experiencing these issues. And something as simple as Viagra is not helping. And there are definitely surgical options for urinary leakage as well. One thing for the women on this slide is just to remember that providing a safe environment for men to talk about these options is very important. So sometimes that's something we're going over in our office too, is just to look at, allowing him to explore what he really needs to be able to have an erection again, to be able to bring back that libido, those kind of things. So providing that safe environment for him is very important.
So some of the things that are really common for both males and females when they meet with us in survivorship are things like depression, anxiety, and fatigue. And those really across the board are going to affect sexual functioning. When I'm feeling very tired, I've worked a long day, patients are reporting, I'm not in the mood to go home and have sex. Depression, anxiety, performance anxiety is a big thing that patients talk about. I'm afraid that I'm not going to look the same while I'm having sex. My partner's not going to perceive me as sexy anymore. So those kind of anxieties come up a lot. So we talk, in our sessions, we do provide counseling to help with performance anxieties, different specific ways of reaching orgasm, because oftentimes that can be different after treatment. Whereas some women, nipple stimulation was very helpful in reaching orgasm before. After surgery, that may be really difficult, so we may explore different ways. And I think that in the setting of meeting with both a counselor and a nurse, and we're really talking about we're talking things through very specifically with patients in their comfort zone, and we're talking about it outside of a sexually charged environment. So if I'm working with a patient who says in the heat of the moment we can't figure out how to solve this solution, I'd come back with, well, in the heat of the moment you're not going to be able to get and there's so much anxiety and there's pressure, and our clothes are off and there's body image issues, and it's just not a good time to talk about that stuff. So we really encourage patients to consider talking about these things, with a facilitator or with each other, but not in the heat of the moment. And so that's really important, this idea of communication and honesty. So just talking with your patients, talking with your partner about body image changes. Again, we'll go back to that describing individual needs and desires. It's so important for patients, again, when things are not sexually charged, to talk to each other, talk to your partner about what your individual needs are. If it's driving you crazy that your partner doesn't make the bed in the morning or he doesn't kiss you goodbye when he leaves for work, you need to say those things, because your partner may not be perceiving that that's a barrier to intimacy for you. So, and then the final thing, really important, is considering where your spouse is at or your partner is at. Oftentimes we hear from partners, caregivers, spouses, lovers that, listen, they've been in cancer treatment, she's been going through chemo or she's had surgery, and I'm afraid to hurt her. And I'm afraid to touch her there, or I'm afraid to do this. And so really just kind of talking through that often can kind of dispel myths. And also that's where it comes in very handy to have professionals in the room with you, because we've heard myths all over the place and had to go, whoa, 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 that's not how the body works. And I think that sometimes can be very relieving for our patients to hear. All right.
So looking at solution-focused care for couples, we really do love when we see couples come in together because oftentimes that means communication is open. It's important, and I feel like Britt and I, for the most part, will listen to patients for a long time before offering anything. Just because we really have to listen to, as patients describe their specific situations. We have to help them to possibly adjust expectations, looking at what could be changed about this situation, also validating their experiences, really normalizing some of the things that they're going through can sometimes just provide that, just what they needed to hear that day, to kind of normalize that experience for them. And we do provide basic education on anatomy and pleasure. And I think that's really important. We actually recently have medical models of both the penis and the vagina in our office to be able to show patients exactly what things look like, and how to maybe focus on pleasure rather than on orgasm in certain situations.
Yeah, and I think those models have definitely sparked some interesting conversations and questions in our office. So I do want to share a story about realistic expectations. We had a patient, and this really also goes back to this idea of, we listen to our patients for a very long time before we start to offer specific suggestions. And I think this story will illustrate why that's really important. I had a patient come to me recently, quite recently actually, who initially had said she wanted help with low desire. This is a patient in her mid 60s, and she had been partnered for about 35 years. They had good communication, she reported, and she really wished that they were having more intercourse. And so initially, that is the direction I started to go with her. So we talked about ways to increase desire. But as we slowed down and as I listened to her more, it became very apparent that what she really wanted was to communicate to her partner admiration and love and affection. And so finally, I asked her, how often are you having intercourse with your husband? And she reported that they were having sex one or more times a week. And I'm sure my face gave it all away, but I had to tell her and normalize that that's actually quite frequent, and that she was above average for relationships in general, let alone a 35-year relationship. And we talked a lot about how as we age, we have less hormones going through our body. We have less desire, but we have more of a need for affection, for companionship, and when we value things a little bit differently. So we really focused on talking about how she could communicate to her husband that affection and that connection that she was feeling with him, but also how she could increase pleasure during that experience that she was having. And that's really where our focus stayed. And she had some very strong values and beliefs that I think we were able to very nicely work within. And it was definitely, to me, a reinforcer that we need to slow down and listen to our patients and read not only what they're saying, but what is the intent, what's the process, what, not just the content of what they're telling us. So one of the things, again, I'll comment on for both couples and for the patients that we see individually, we're really focusing on pleasure rather than orgasm. Sex is a journey. It doesn't have to just be a climax. This idea of sensate focus is something that we talk a lot about with our patients, just being very much present with your body, kind of getting out of your heads a bit, having less thoughts about this performance anxiety, things like that, and paying attention to what feels good, what doesn't feel good. Oftentimes, if patients are comfortable, we'll explore this idea that this is something that can be explored on your own. So, self pleasure and exploring what feels good and what doesn't, so that when you are with your partner, you can strongly communicate, okay, this is what I find is working and this is what's not working for me. Couples that are even very good communicators don't always know how to ask for the things they need. So, again, finding that allowing them to tell one another what's necessary to get in the mood is a good learning experience for both of them and can be very healing. We have discussed the option of toys and devices with a lot of our patients. Many patients are very comfortable with this. And so we kind of discussed the difference between a vibrator or a dildo, what is most pleasurable for some of our patients in the past. So we're just very, very mindful of what's comfortable for some patients, again, using the Plicit model. We discussed this idea of outer course, which is for patients that cannot have intercourse or penetration, how to pleasure each other without having that. And again, going back to this idea of brief solution focused couples counseling.
So let's talk about sex, right? Not all healthcare providers, unfortunately, are comfortable talking about sex, let alone specific desires, behaviors, or needs that patients may have. And sometimes even the best intentioned doctors or nurses may be giving off this kind of body language that says, whoa, I'm not ready for this. We really want you to take home the message of how do I bring this up? How can I talk to my healthcare provider about this? First of all, really identifying if you're in a helpful setting or not. Um, if not, it's more than comfortable for you to ask for a referral. Doctors are used to this. They know that obviously they're not always going to be the most knowledgeable about every subject. Really meeting with someone who is a lot more knowledgeable about the subject will help you feel more comfortable. And plus, knowledge makes people more comfortable. You'll have a much easier time talking with a professional who knows the subject and wants to talk to you about it as well.
So we'd really like to open it up now for any questions that you may have. And we ask that you keep your questions pretty general so help as many people as possible. Um, so if are we?
Thank
Yes,
you.
yes.
Thank you, ladies. Hello. Yes. Okay. This is Kelly. Thank you so much. That was a great presentation. Very, very informative. And we will now open it up for questions and answers. And if you could start typing your questions, and we will respond accordingly. And actually, one of the first questions we have is from Rose Thomas, who wants to know if this PowerPoint will be available for download. And yes, this presentation is recorded, and it will be available for download
Okay,
within a
thank
week.
you, Kelly.
Okay. So we can start the question and answer session now. If you have questions, please start to type and we will get you a response. Okay, Angela and Rose are typing at this time, so we'll give them just a minute to type their questions. That was really a great discussion, and even as a non-survivor, I learned some things. And actually, one of the things that you said, sex is a journey, not just a climax. I thought that was that was a powerful statement. Believe it
Great.
or
I'm
not.
so glad to hear that that was helpful.
Okay, I
So
have a
the
question.
first question that
You said I can't hear you. Can you
is
speak
this
up a little?
better? Okay, great.
Yeah, now I
So the
can.
first
Okay, go
question
ahead.
we have is the name of a vaginal moisturizer that we recommend. The name of that is Luvina, and we can type that in so that you guys can see that as well. Luvina is just one of the products that we recommend. Again, there are many vaginal moisturizers. I'm sorry, I'm going to type this in. We had someone who was trying to type that in, but it's a tricky name. Luvina has cranberry extract. It's free of parabens. It has prebiotic things like that. So it's a very nice product. Patients report that they like it. Again, the other thing that we recommend that there's actually been clinical evidence that's helpful is vitamin E. So, and these would be a capsule that you would actually insert into the vagina, and that is something that you can purchase online. One of the manufacturers of that, the product is called Key-E. And this is something that I had just been introduced to actually recently. So, and I'll type that in as well. But also just using like a olive oil or a coconut oil. Some patients swear by that. Again, just making sure that you're talking to a healthcare provider to make sure that whatever it is you are using is safe. And again, we tend towards hormone-free products.
And it is really important with the vaginal moisturizers that you are using them 3 times a week or less. So just following the package directions on that Luvina is very important. Patients can kind of just do some other things to their vaginal walls if they're using it too often. So sometimes people feel that, this feels great. I'll probably use this every day. But we want to just really caution you that 3 times a week is the maximum time that you should be using that.
Yeah, as Heidi is mentioning, you can really upset the pH balance of the vagina if you're using this too often. We kind of compare this to a pool sometimes, as we want to make sure that there's just the right amount of everything going on in the vagina to make sure that it's healthy and supple and not overly moisturized. And again, with this, the moisturizer, we want to make sure that you're having vaginal comfort before you're having intercourse. So if someone is experiencing vaginal discomfort or pain during intercourse, we kind of want to push the pause button on intercourse because the vagina, as we had mentioned, can actually suffer trauma, and that trauma can cause further tightening. And so that's something that we would refer out to physical therapy, but we would also just say, push the pause button. Let's take care of vaginal comfort. Let's make sure that we're doing the moisturize, stretch, lubricate, and then get back to intercourse as it's more comfortable. So thank you for that question. It looks like we have another question that's just come in. As a 14-year survivor, none of my medical team talked to me about sex. I hope this changes in the medical community. Thank you so much, Rose. I think that you make a really good point, and we have noticed this as well. That we really hope that going forward with more research and with more patients speaking up about it, that it's something that changes in the medical community. So we really appreciate you, the sentiment there. I think that you're absolutely right that many patients are acknowledging that no one really talks to them about sex. So.
And that's one of the things as from Sisters Network that we want to make sure that we can bring this information to the survivors in our network. And this is information that the women have asked us for. And all of our webinar topics are things that women have requested and want to learn more about. So we really thank you for that and being able to provide such good information for the ladies, for the survivors today. Well, it appears that we don't have any more questions, but we will, if you maybe were not comfortable with asking your question here on the webinar, we do have an email address. Do you mind, or I can type in Katie's email address to send emails to real quickly, if I can grab it. Kate Peterson. Oh, you already done it. Okay. All right. So you can send any additional questions to kate.peterson@ctca-hope.com. And again, thank you so much, Marilyn and Ashley, and those for your comments. And we hope that you will download the presentation and send that information and share that information with your network as well. Now, we'll close out in just a second. Just a couple of notes from Sisters Network. Again, we want to thank Cancer Treatment Centers of America for their support of Sisters Network, our webinar Wednesday. You ladies were fantastic. And if you are in the Houston area, for those of you who are on the webinar, join us for our Survivor Socials that we host here at Sisters Network. And those dates are on our website, which is sistersnetworkinc.org. And of course, please join us on Saturday, April 5th for our national walk that's going to take place at Discovery Green Park in Houston, Texas. And that walk supports our breast cancer assistance program. You can register for that at stopthesilencewalk.org. And registration is now open. And also, Sisters Network is celebrating 20 years of survivorship. So please join us in Houston for our national conference and Pink Angel Awards Luncheon and Style Show, October the 9th through the 14th. And registration is scheduled to open on March the 1st. And you'll be able to register online through our national website, sistersnetworkinc.org. And again, thank you so much for your support of Sisters Network and all of our programs and services. And on behalf of Sisters Network, thank you for joining us for Webinar Wednesday. Until next month, enjoy the balance of your life. Thank you so much. Have a great day.